Hi, everyone. Welcome back to the podcast. Today, we're here with Dr. Sonia Kupfer. She's an associate professor of medicine at the University of Chicago. She's the director of the Gastrointestinal Cancer Risk and Prevention Clinic there. And we're going to be reviewing an article that she was just part of. It was an updated clinical practice guideline for hereditary diffuse gastric cancer. It's published in the Lancet Oncology, volume 21, August 2020. And the first author is Vanessa Blair, and the last author is Perry Guilford. And this is an update to the International Gastric Cancer Linkage Consortium Management Guidelines for Hereditary Diffuse Gastric Cancer that was published originally in 2015. Welcome, Dr. Kupfer.
Thanks for having me, Dr. Slavin.
It's exciting to be on the CGA podcast. So, we just wanted to cover your perspective of the article. And we can start, I guess, just what were the major goals and findings in your mind of this article?
Sure. So this was part of the, as you mentioned, the International Gastric Cancer Linkage Consortium that has been meeting approximately every 4 to 5 years to update this area of genetic testing and management for hereditary diffuse gastric cancer. And I was lucky this year to be part of this fantastic group, multidisciplinary group of clinicians, pathologists, and in particular also advocates and patients. And so the perspectives were really amazing to hear as we were revising the guidelines from 2015.
Yeah, that's great. What really, I guess, pushed this to publication this year, since it's kind of a standing meeting?
So I think there have been a lot of changes in this area. As you know, CDH1 was discovered in the 1990s, so it's a relatively newly discovered syndrome. And over the last 5 years since the publication of the last guidelines, there have been changes. And in particular, the advent of multi-gene panel testing and inclusion of CDH1 in particular has led to some new insights or observations about this syndrome and the phenotype. So it was ripe for an update.
Yeah, to say the least. We've all taken care of many incidental CDH1 patients. And so what do you think the major impact overall of this article will be on the field?
Yeah, so I think there were a number of important changes that were made from the 2015 guidelines. In particular, the syndrome has sort of been redefined in some ways, or at least had the recognition that it's not all gastric cancer, for example. Mm-hmm. So you'll see in the article there are definitions of what HDGC or hereditary diffuse gastric cancer is referring to. So it's really individuals with a pathogenic or likely pathogenic variant in CDH1 or a smaller group of individuals with the variants in ctNNA1 who have a personal or family history of diffuse gastric cancer. Included now is hereditary lobular breast cancer, which is individuals with CDH1 pathogenic variants who have a personal or family history of lobular breast cancer, but no diffuse gastric cancer in the family. And then a third category, which is the HDGC-like group, which fulfill clinical criteria, which were also updated in this guideline, but in whom no mutation is identified. So I think that was a change from how the syndrome was described in the previous guidelines.
And what about changes in the management? What do you see new in this one versus 2015?
So one of the other major changes was in genetic testing criteria, or in whom to consider genetic testing. And most of it had to do with a bit of relaxation, especially in terms of ages of individuals and whether they would meet the criteria. So as an example, for individual criteria, anyone with diffuse gastric cancer under the age of 50 should be considered. Previously, that was age 40. And then there were some differences in lobular breast cancer where the age was raised to anyone under the age of 70. So I think that relaxation is a recognition that the phenotype that we're learning about now is different, and the ages may be older actually in families. In terms of management issues, I was part of the endoscopy and surgery working group. So the way in which this guideline was written is that we were grouped into our different areas of expertise. So as a gastroenterologist, I was with other gastroenterologists and surgeons, and we were particularly interested in what has changed in terms of endoscopic identification or surveillance in gastric cancer. And it's certainly still a challenge. It's still a bit of a needle in a haystack, but we've come to recognize that especially at centers where we see a lot of these patients for surveillance, that there are some very subtle features that might identify areas of signet ring cells, such as this pale mucosa and other kinds of endoscopic features. So certainly recognizing those and how to take more targeted biopsies. The random biopsy recommendation is still there. There were some changes in the recommended distribution of where these biopsies should be taken, some more in the body, as well as the fundus and cardia. So those were some of the endoscopic changes, at least in terms of surveillance.
Yeah, and it seems like one of the bigger management changes is kind of a step back from just going with recommendation to remove the stomach and looking at the family history, trying to figure out if there's lobular breast cancer in the family history and or gastric cancer, using that and the decision tree to move some individuals out of recommended prophylactic total gastrectomy to annual gastric surveillance. Any comments there from what you saw on the group coming together around that?
Yeah, I think that's a great point. So I think one of the areas certainly of uncertainty remains what is the gastric cancer lifetime risk in families, for example, who have only lobular breast cancer and no diffuse gastric cancer, or in individuals who have variants of uncertain significance who might meet criteria. So can we manage those individuals with endoscopic surveillance? There was some controversy about this, of whether it shouldn't just be total gastrectomy, prophylactic total gastrectomy should be the recommendation for anyone with a CDH1 pathogenic variant, because we know that on gastrectomy, 95% of these individuals will have identifiable foci of signet ring cells. But there were other discussions about what about individuals that choose not to undergo gastrectomy? And I certainly myself have patients like that. And can we optimize endoscopic surveillance so that we can at least find tumors in earlier stages? Can we do anything with endoscopic surveillance?
Were there any big challenges from your vantage point with finalizing the article?
I think there were, as with any group discussion, there were areas of controversy. And if you look in the article, actually many of these made their way into the appendix, where there's a whole table of research questions that we would love many that are listening to this podcast to tackle. And I think those came out to a certain extent in our discussions. I think there were controversies in our section about, for example, do we have data to support screening them for 2 years and then extending the interval? But you'll find many of those topics just lack data. And so that is why more research is needed on a lot of these topics.
What is really needed to move the field forward even more?
There were a number of areas that were identified. So I think we definitely need information about penetrance and risk prediction. And as I mentioned, as we're finding people who don't meet the classic phenotype, what are their actual risks and how can we use those to better guide patients? Questions about why do these signet ring cells start to grow into the lining of the stomach? What is that second hit that is required? And is there any way in which we can intercept that process for our patients so that maybe in the future we don't have to do total gastrectomy as the only option? I think there were questions about cancer surveillance and risk reduction measures, and then long-term follow-up. How are we doing that? One of the interesting things in this guideline that I'll just point out is there was also a section on pharmacology and considerations of post-gastrectomy care, which I thought was incredibly helpful and very practical because it's not something we always think about for our patients. There were questions about variants of uncertain significance and how can we better classify these variants, and that comes to bear especially with CTN and A1. So lots to work on.
And that was a new add to the guideline as well, the CTN and A1 mention, which is a a gene that works closely with CDH1 that's been noted in many families that look like they have hereditary diffuse gastric cancer or features thereof. Can you elaborate on the discussion behind pulling that into the guidelines?
I think it was the recognition that families that meet criteria who were not being found to have mutations in CDH1 were found to have pathogenic variants in CTNNA1. I think there's still lots to be learned about the phenotype.
Mm-hmm.
Right now, we're treating them with endoscopic surveillance, surgery, discussions based on findings, or perhaps based on cancers within the family, but still emerging field.
Yeah, absolutely. Well, thank you, Dr. Kupfer, for being on the podcast today. It's always a pleasure. You are an amazing clinician, and I always look up to you. I know you've helped many, many people on this planet, so thank you so much.
Thanks so much for having me. And I just want to point out, this is really the work of a worldwide consortium of fantastic clinicians, pathologists, basic scientists, and importantly, advocates, without whom this kind of work would not be possible.